So what Lizzie's going to walk you through is sort of the first, I think, globally, really to address some of these key issues that we're going to be sharing with you and give you hope around the idea that work is in motion for us to be able to prevent inflammatory bowel disease. So that is where our work is really focused. And again, without belief and commitment to this kind of work, these kind of transformative projects would not be possible because the NIH, be it today, but also historically, aren't willing to take risks. And it's really philanthropic community support that gets really the research done. So again, thank you. And so Lizzie's really been the brainchild behind most of what she's going to show you today, and sort of living out sort of the global aspect of preventing and precision in IBD. So Lizzie, I'll turn it over to you.
Yeah, thanks, Marla. And just to set this up, I'm calling this a patient-centered IBD research journey. And there's really four parts to it because I'm sort of taking you through sort of the IBD life cycle a bit. So I'm hoping to A, stop it first, which is that prevention. So we're going to talk about prevention first. And then we're going to talk about choosing kind of the best therapy up front so we can kind of nip it in the bud and prevent any complications. Um, and then we're going to talk about how to best monitor it to make sure that we keep it under control. And then we're going to talk about refractory patients and getting a little bit creative, which that's Marla's bread and butter, and she's passed that on to me as her mentee. So we'll talk about one of the ways that we're getting creative at Mount Sinai of many. Um, so as she was saying, sorry, let me get my slides going. Sorry, I got clicked out. Okay. As she was saying, the first kind of thing we're doing is we're really thinking about stopping IBD before it even starts. Um, and Marla and Jean-Fred Colombel at Sinai have been really instrumental in being champions of saying this is possible, this is something we can focus on in inflammatory bowel disease. This is one of the ways that we can connect to a cure is actually through prevention. Um, and so they've sort of given over control to Ryan and I to get this off the ground and running, which would be the first in the world clinic for focusing on the prevention of IBD. And we really wanted to focus at first on family members of patients with IBD. So these are their children or siblings or other family members, and really give them agency over the risk that they carry related to their family member through education, through guidance that we offer on their red flags, and through also enrollment in trials where we can institute preventative measures. And so this sort of a lot of this too in making this talk about an IBD research journey. So a lot of it was rooted a little bit in my own journey as I'm an IBD patient. I was diagnosed at the age of 15. And my grandma and my aunt both have inflammatory bowel disease. So my mom took me to the doctor and said she has IBD. I know it because of our family history. And of course I did. But then since that time, my brother and other family members have also been diagnosed. And now I have two kids. These are my two little boys. Um, and I really wanted to think a little bit more deeply, can we not bring preventative strategies? We have a lot of associations now through work that we've done at Mount Sinai. We've done a lot of work to predict risk in people, to think about ways to intervene through our PREDICT study, which is looking at Army recruits, where they've done blood samples in the years before IBD was diagnosed. And they were actually able to find things in the blood that were predictive of the later development of IBD, even 7, 10 years before patients were diagnosed. And then meconium, which my own two sons are enrolled in, is looking at infant stool and seeing if there's anything that you can see in the baby poop, the meconium, and then the later stools of the kids as they're growing up. And is there any way to intervene in pregnancy with a dietary change? That was the Melody study, which was a twin to the meconium study that can actually affect changes in these kids. And through this, we've really discovered a lot. We've found that there are a lot of markers that we can look at that can tell us who might be high risk. There are things that we can potentially do in the diet and the environment that do reduce your risk. So from that was sort of born this idea of let's bring it all together. Let's actually make this happen in a clinic. So this clinic is sort of based on three different principles. The first two, I would imagine you sort of understand just from having a prevention clinic. One is we want to predict who's at risk, and the other one is we want to prevent. That sort of makes sense. But then the other underlying goal of the clinic, which maybe is not so obvious at kind of on its face, is that when we follow folks who are high risk and they develop IBD, we learn a lot about the disease. And so the kind of third pillar is to really pursue a cure. We call it the three Ps kind of our prevention clinic. And we're working really closely with all of the great researchers we have at Sinai to make this clinic also really a great kind of seeding ground for better understanding how IBD starts to happen and trying to, again, stop it. And then maybe actually understanding how it started and how we can cure it, how we can change it in people who already have it. You might say, well, you're really biased. Obviously, you're really self-interested in this. Are other people as interested? Would they be as interested in doing some of the things that you might propose in a prevention clinic? And so there was a really large survey that Joanna Torres, who's one of our colleagues in Portugal, did globally. Over 1,000 parents with IBD or other family members of patients with IBD. And she asked them, would they want predictive testing to see their risk? Would they want preventative interventions that they could do in themselves or their children? And most people did. 85% wanted a predictive test. 97% would do some sort of preventative intervention. So nearly all. Most of the predictive testing they wanted were blood and stool, although over 50% would do an ultrasound, and a third would even do a colonoscopy. For preventative interventions, most people were interested in dietary interventions. There were a number of different questions asking about diet, and that was what people were most interested in. But even around a third would do our therapies that we have for inflammatory bowel disease, either oral or injectables or infusions. And they're doing a study now in Europe called the Intercept trial where they're going to do this. They're going to look in high-risk family members and give them vedolizumab or Entyvio, one of our therapies that we can use that's either IV or injection, to folks in Europe, 16 and up, to see if they can actually change the course of IBD. And our idea would be that we're doing sort of the same, but through a number of different modalities here, not just Entyvio. So how would it work, you might ask? Like I've been to a clinic to see a doctor about a problem, but not really about a preventative problem. Although when people say that, that's not totally true. I think we're just not used to thinking of it in this way for IBD, but you do probably go to the clinic a lot for preventative issues with your primary care. When they take your blood pressure and they look to see what your blood pressure is and they give you a blood pressure medicine, that's preventative care. So the same could be used for inflammatory bowel disease. So how we envision this is that this would start with first degree relatives. Later, we might open this up to like second degree relatives. We might later open this up to just people that we can identify through either genetic or blood markers through large databases that we have at Mount Sinai. But we'd start with first degree. They'd check in. They would meet with a coordinator and do a number of questionnaires. But these questionnaires aren't just kind of for research. They would really be more tailored at what can we modify in this person? What risk factors do they carry that we can actually change that would reduce their risk of IBD? So for us, we were going to do red flags, which is, do you already have symptoms that might mean you already have IBD and you just don't know it? We were going to do a dietary screener looking at, again, things that we could change that reduce your risk of IBD. An environmental screener, again, looking at those modifiable things. And then just a stress kind of scale to see how stressed you are, to see if we could perhaps teach you some stress and resilience skills. And then from there, they would go on to get an intestinal ultrasound, That's just one thing I have expertise in, which really allows us in a non-invasive way to look at most of the bowel, most of the colon, and the end of the small bowel, and see if there's any inflammation. So a great kind of early screening to say, do you already have signs of IBD, and do you need to be worked up more thoroughly? And also really nice to show to patients you don't have any overt signs of IBD when I do the ultrasound. So even a negative test, I think, is a really nice thing for these high-risk family members. Um, and then they'll actually go into a visit with either myself or Dr. Ungaro. We'll review the ultrasound findings, we'll go through the risk questionnaires, and we'll actually make a personalized strategy for them based on their what they've filled out in their questionnaires and also their family history. For example, my family's much more colitis. We don't have small bowel Crohn's. And so when you have a colitis phenotype, the dietary changes you can make are actually a little bit different than if you're a small bowel Crohn's. So we could really tailor that to the specific patient. And then they would go to a blood draw and a stool kit, and these would be for returnable results. So calprotectin, which is a marker of inflammation from the poop, um, and then we could actually give that back to the patient to say your calprotectin was normal or it falls into certain ranges that we'll discuss in a second. And then we do a blood marker that builds on all of our great findings that we've had in our other studies, the Army study that I was talking about. And then also, I have a multiplex families group that Dr. Dubinsky set up with our Orthodox Ashkenazi Jewish population. And we've from there really been able to kind of give a really great score based on blood markers that can tell us a little bit about the stool. So we would be able to return sort of a risk percentile to our participants as well based on that. And then we would decide on follow-up based on all of these things. So we'd kind of put people into a risk cohort and then decide on how their follow-up should be. So if you wanted to kind of follow along, we have this is the algorithm that we've come up with. Quite a bit of work, quite a bit of input from kind of global experts. And we made it into an interactive algorithm over here. If you scan this QR code, that you can actually test out different use cases yourself. But they would get that kind of initial group of things that I was saying earlier. And then if they, of course, have a symptom screen that's positive, which are really severe symptoms like perianal disease or blood in the poop, something that's a red flag, it's a validated index that we have, then they would go actually for same day evaluation in our clinic. So sort of rapid fire evaluation and decision on colonoscopy. If they have an abnormal abdominal ultrasound, or two really elevated fecal calprotectins, that inflammatory stool marker, then they'd also go for an evaluation by one of our IBD doctors. And then we could decide on if they need a colonoscopy. If they have more borderline fecal calprotectin, then we check a few times, see kind of if they fall in that borderline range a few times and aren't rising, then we might just follow a little bit more regularly on a yearly basis. And then last but not least, if everything else is normal and they just get to the blood test stage, if their blood risk score is higher, then they can also go to a yearly follow-up. And if all of these things are negative, I think that's also really great too. That's super reassuring that you don't have any red flags. You have a normal ultrasound. You have calprotectin that's totally normal, and your serologic score, so the blood score, is low. To me, that would be a great finding for a patient too, and they would go then into a 2-year follow-up kind of arm. And then we would just follow folks and we'd be able to provide them with new information each time about IBD risk and education on what we've learned because, things are moving fast. We're learning more kind of each and every year about the different things that we can do to reduce risk of IBD. So this is sort of our algorithm as it stands, but we see this as sort of a living document because again, we're learning more things. Even in a pilot of this program, we might learn kind of the percentage of people that go through the algorithm and get to the 2-year versus the year and be able to kind of tweak it on the fly. So that's our algorithm. And then we're planning to open in September. Um, but I put this QR code here because I know you all are very interested in a cure and this idea. So this just includes, it's a two question survey. One is just if you had any thoughts that you wanted to share and you didn't want to share here. And then if you want to put your email in, we'd be happy to reach out to you with information on the clinic as we open. But I don't know, this might be a nice place to stop. I don't know, Marla.
Yeah,
Yeah.
so there was a question about ultrasound, so we're going to wait because you have even more data to share on ultrasound, and then we'll come back to the question because it's about what's the role of IUS. And I think once you talk about it as a monitoring tool instead of replacing scopes, but we'll get to that in a minute.
Yeah. So this is using ultrasound in a different way. People would still go to colonoscopy if we're really suspicious of IBD from their ultrasound. It's not yet a way to diagnose, but we're using this in a non-invasive way because we imagine from our, so we have, there's a big Canadian study called the GEM study, and they looked at first degree family members and they followed them over time. And what their numbers tell us is that most patients are going to go into that 2-year follow up. They're going to get very reassured by this data. And there's not that many who's going to have an abnormal ultrasound. We did this in these multiplex families, and we actually did ultrasound, and most people had a normal ultrasound. So we don't think we're missing a lot of like obvious IBD. We're really tracking people before disease, which is really the point of this clinic. We want to prevent it before it starts.
Yes, so the Lizzie will get into a little bit about how we're using ultrasound in the practice for those that are already diagnosed, but essentially we've come to a point in IBD just in general is that what is the exact role for colonoscopy? One, a diagnosis to make the diagnosis. Two, everyone needs a treat to target colonoscopy, which means when you have begun a therapy, you need proof within 6 to 12 months after starting that you've achieved the outcome of endoscopic response, but more importantly, probably endoscopic healing. And if you don't get there, then you have to reiterate and iterate and add therapy, restart another therapy, optimize the therapy you're on. And instead of doing a scope again, the goal would be that you start to bring ultrasound into how you know that your treatment optimization strategy works. You're not keep scoping somebody every time that you make a change in treatment. But the most important scope is within a year of starting a therapy to mean that you've reached the target for which you've used the drug for. Symptoms alone do not equate to outcome. They make patients feel better 100%, and our goal is to actually make sure that people feel better, but symptoms do not associate with long-term prognosis. They're just a short-term window into the fact that patients feel better. But the data is very clear. By asking people how they feel, we have not changed the surgical rates of IBD. The only thing that changes the natural history of inflammatory bowel disease is if we heal the lining, the colonoscopy. So that is why the mandate is what we call a treat to target colonoscopy. Now, ultrasound's role, and then the third scope, before I get into ultrasound, the third scope starts when you need colorectal cancer screening, which means after 8 years of the disease. For people with ulcerative colitis, 8 years after the disease, we need to start doing what we call surveillance colonoscopies, which is done, as I noted, 8 years for UC patients, and for Crohn's patients who've had at least a third of their colon, they fall into the same colon cancer screening strategies. And it used to be, some of you may have experienced it, that we used to do yearly colonoscopies for colon cancer screening. And then we started having very good therapies in our ecosystem that we were able to achieve better inflammatory resolution under the microscope, as well as at the time of the scope, to like us as at the time of the endoscopy, what the pictures look like. And so the newest guidelines suggest that we can move to every 3 to 5 years, and some people could move back out to every 10-year, just like the general population, once you've done your 8-year scope. So there's a lot of evolution in colon cancer screening, but that's where colonoscopy and an ultrasound can't detect biopsies, right? So where biopsies matter, you need a colonoscopy. Where you want to just make sure that your treatment is working, that's where ultrasound comes bedside, real world decision making. I don't need to scope you to tell you that this drug is not working. I don't need to scope you to tell you that I need to adjust your treatment dosing. So, ultrasound, which Lizzie will talk about in a minute, is really about, as noted, about disease monitoring. And it is so predictive of a scope that even in clinic we'll say calprotectin plus ultrasound equals colonoscopy. I don't need to scope you to tell you that you have active disease. Your ultrasound and your calprotectin are enough. And that's sort of where we're trying to teach the planet to stop scoping unnecessarily if you implement ultrasound at the bedside. So that's aside. The next question, Lizzie, which you can absolutely address because you've
Yeah.
already had discussions about scaling. So maybe talk about your plans for scale.
Yeah, so we would be the first in the world prevention clinic, and there's actually some precedent for this in type 1 diabetes, where they have really scaled nicely across the world, actually, in their prevention efforts. And as such, they actually have some approved therapies for preventing type 1 diabetes. So we're taking a cue from them. And actually, we had a big discussion with the leader of their kind of prevention group to help us in our design. So we see this really more as a kind of a short-term pilot to firm up all of our kind of plans to make sure everything functions. And the other thing is we have Lori Kiefer, who's our amazing psychologist, to make sure that we're providing the psychological support and that this on a whole is a good for patients, which kind of inherently I feel like it probably will, because I think we're going to be telling a lot of people that they have less risk than what they assumed. But we want to confirm that that's the case before scaling it widely. And then we already have a lot of potential partners across the country and then across the world, even who would want to roll this out in their own center. And we've considered there's a grant mechanism that helps us to collaborate across the country called a U that we're really considering down the road to help us to make this really wide reaching effort. So a lot of interest across the country. It's just nobody's actually gotten to the brass tacks of planning how it functions and what we send, which is what we have taken a leadership role in making come to life. Because you can debate forever, right? Those two things that I showed you, how the clinic functions and how the algorithm goes. But what our type 1 diabetes colleagues told us is just start. Just start. You're going to figure it out ultimately. If you debate forever, you're never going to start. So that's where we are now.
We're kind of Lizzie and I were already doing it in a sense, to be
Yeah.
fair, because Lizzie is an expert also in very early onset IBD and would often get the siblings, younger or around the same age of those individuals that were diagnosed, and she had to do her own counseling and talk about avoiding antibiotics in the first year of life, adding five, there are definite things that we know are associated with the development of IBD, and these are some of the lifestyle and diet interventions that we'll be actually implementing. So she was doing that already in her very early onset clinic, and I do this every pregnancy clinic where I am counseling moms who are pregnant on what to do to minimize the risk to their offspring. So we were already sort of doing it independently in high risk populations. And what we want to do is bring it into a more formal, protocolized way where we're consistently giving the same information so we could study it so that we can actually scale it globally, right? So we wanted to formalize and bring it all under one prevention umbrella. So we'll see siblings, we'll see pregnancy patients anybody who is a risk as a family member, someone who has psoriasis in their family, right? Because those are other inflammatory diseases. So it's not just focused linearly on one population. It is anybody who by genetic underpinnings, because none of these diseases happen without genes, just as a reminder. They are all underlying genetic diseases. There's not one gene, there's hundreds, so there's no way we have a genetic cure, of course. It's not like cystic fibrosis, where it's one gene essentially, and you know what happens. These are not autosomal recessive diseases where there's, 300 plus genes. So that's why we can't get a handle on this thing. And that's why we don't have a cure. So there's really the complexities around it are very different, and risk is determined in many different ways. So we're going to see all people who meet a criteria of being at highest risk by way of genetics. So that's an important distinguishing quality as well.
And then I also think that we're going to get a lot better data mining. I mean, I think we're all seeing that AI is starting to change things. And at Mount Sinai, we have something called the Mount Sinai Million, which is where we're getting whole exome sequencing. That's like as much genetic information as you can possibly get. We're getting that on 1 million patients. And I think that we'll be able to probably take that data and take those highest risk folks, even if they don't have a family history, because most people still actually don't have a family history, even though it remains our biggest risk factor for IBD. Most people still don't have that when they get IBD. So we'd be able to actually look at that genetics and maybe pipe those people into the clinic in the future with a different set of concerns, right? With someone who doesn't have any sort of background in IBD, like a first degree relative. But there's a lot of kind of future legs to this. And then Marla already hinted at one, which is to look at these other very kind of co-occurring diseases like psoriasis and think of, should this really be an IBD prevention clinic, or should this be an immune-mediated disease prevention clinic? And so that idea of scale, you could think of scale in kind of space, but you can also think of scale and scope, which I think we can scale it in so many different ways. And I do think we should work a lot more on prevention in these immune-mediated diseases, especially as they've risen so much in time with our industrialization that we have. Um, so let's go to the next kind of phase, which this one you all provided funding for, which was amazing and really helped us to kind of kick off the skin taping program that I'm going to talk about. But it's all rooted in choosing the right therapy. Um, and so aside from prevention and trying to stop it before it starts, I think one of the biggest problems for patients with IBD is that we still, even now, 2025, we cannot really pick kind of the best therapy. Marla and I think we can like elegantly try to pick by looking at family history and looking at personal history, and we are pretty good, I gotta say, but we aren't using science really to back our choices yet. We aren't like using any gene expression profiles. We're not looking at exactly the patient's biology. We're doing sort of a poor man's way of trying to get at it with our family history questions and our personal history questions, but we're not actually getting the data yet. So we said, how can we get the data? And most people would say that you get that from biopsies. So again, this idea of you have to go do a colonoscopy, get these biopsies, and from there you can then pick therapy. That just seems like a lot for our patients. So we wanted to know if we could do that in a less invasive way, still get the biology question answered, and then get a better idea of what therapy to start, or maybe therapies. We do a lot of dual therapy, and our thought is that maybe a lot of people need dual therapy up front, and we're doing them a disservice by having them fail every single therapy until they can get to dual therapy, when they could have not gone through quite a bit of pain in all those trials and failures. You labeled as a failure often as an IBD patient, which is just psychologically very painful to have to go through that. So in that, we also, beyond the sort of psychological trauma that it creates for patients with IBD, there's also true trauma to the bowel that it creates. And so if you have that classic relapsing remitting course where you're having flare after flare after flare, you're accruing bowel wall damage over time that we can't reverse yet. Of course, there's work on trying to reverse that damage, but we can't, as of 2025, reverse it. So the idea is the earlier we intervene and get things under control, then you can just keep it at a steady place and you don't have any more of that damage accrue. And you don't need to have complications occur. You don't need to have surgery because we've maintained it over time. We've kept you in that kind of steady place. So how do we pick then, like what was our idea then to pick the best kind of therapy up front in a non-invasive way using biology a little bit better? We actually looked to one of our most common side effects for a bit of inspiration. So Marla and I would see probably like two patients every clinic with one of these psoriasis-like rashes, which could be extremely severe. I'm showing one here of our patients where you can see there's some alopecia, some hair loss from the severity of the psoriasis. And we actually looked at our patient population, and about 17% have this on Remicade and Humira, some of our common therapies, anti-TNF therapies. And we knew why. There was some biology already to tell us why, that there's this shared pathway of IBD and psoriasis. It's in the IL-23 kind of pathway. And when you give TNF alpha, the Remicade and Humira, it sort of unbalances your immune system and you kind of have that pathway go haywire. And so our kind of gestalt, what we always did with those patients is we would stop Remicade and we would give them Stelara, we'd give them Skyrizi, and they did great on those drugs. But the real rub for this skin problem is that usually their IBD is perfect when they get the skin problem. And there are some people where we said, oh, I really wish I didn't have to stop Remicade and Humira. You're so well on it. Is there something else that I could be doing? I really wish I better understood. And then we also wanted to know, in those, can we predict who those 17% of patients are and just not start Remicade and Humira and give them Stelara, Skyrizi from the start? So we had those kind of two problems. And so we turned to our dermatologist who was doing this cool work with skin tapes. So she would take these stickers, that's this kind of, it's a little circular sticker, and you place it on the skin. You push it down with this little stamper. It's like a little stamp. And it puts some pressure on, and then you peel the sticker off, and it goes through almost like a biopsy level amount of skin, but one at a time, and it doesn't hurt. You don't really even feel it. Sometimes you have a little red mark where that circle was, but even a 3-year-old loved it. I had one that was running around wanting to put more on because he thought they were stickers. And it gives you gene expression from those stickers. So you can actually say, what genes are active right now? What is your biology? What pathway is going off kind of haywire right now? Can we use it to figure out how to treat you? So we did this in the folks with that reaction who had that psoriasis, and we looked because we were seeing that people who had eczema before, even as a baby, when if they had eczema, because we would get, again, we'd be trying to figure out the biology, we'd be asking all these really detailed questions about their personal and family history. But if they had eczema or they had like a family history of psoriasis, they were more likely to get this reaction. And so we wanted to know, were the people with a history of eczema different than psoriasis? And that's because they're different. Eczema and psoriasis have very different pathways. And that same dermatologist who does those skin tapes has actually shown that the skin tapes look very different between eczema and psoriasis. And she was doing that because sometimes the look looks the same to the dermatologist, and they would do biopsies, which were painful and leave scars. So they do these tapes to try to tell the difference, and they could because they were completely different genes that were being activated. So we thought, oh, well, we're going to see that the people who have eczema have an eczema look, probably, to their tapes, and the people that have psoriasis or like no eczema, they have more of a psoriasis look. That was our hypothesis. We were a little bit wrong, actually, because ultimately they both looked like psoriasis. And actually, the eczema people looked like psoriasis times 10, but they also had some features of eczema to it. So it was interesting. It really sort of unlocked this reaction, which people had not, despite it being so common, people had not really well described at all yet in IBD. That it was definitively psoriasis, no matter even if you had eczema. But the people with eczema had this feature of eczema that was actually a drug target. So they had a real upregulation of the IL-4R, that's a cytokine receptor. And it's a target for Dupixent or dupilumab. And Interestingly enough, there were a few folks who Marla and I had seen that had really severe Crohn's disease with perianal disease, and we did not want to stop their Remicade. We wanted to keep them on Remicade. So we said, you know what? We have this hypothesis it's probably eczema. Let's try an eczema treatment. And we chose Dupixent or dupilumab, and it worked. It actually worked in these folks. So even though they have a very psoriasis look, that eczema feature really can change this, the course of this. So those folks did well on Remicade and Dupixent. And so we didn't have to stop their Remicade. They stayed perfect from a Crohn's disease standpoint, and they kept their this skin reaction under control with the Dupixent. Not even long term. We actually were able to stop or reduce the dose in some folks after a while. So it really helped us to better understand the biology in this particular patient population. And then because of that, we thought, well, the skin and the gut, there's this axis between the two, and they immunologically, I can't talk, look very similar. So we were wondering, do they actually mirror one another? So since that time, we've been collecting skin tapes serially in our patients. So we got them before they started a medicine, and then we got them after at kind of prescribed intervals. And then we also got some patients before they started a medicine when they were getting their initial colonoscopy, and we got biopsies at the same time as the skin tapes. And this is what we're going to analyze shortly. But from that, we should be able to say, can the skin, this non-invasive, painless thing, be used to actually predict, not just in this adverse effect, but in any patient with IBD, what we use for therapy for them. And also, I personally think it might be useful for dual therapy. Like if we change the pathway and someone has a partial response, can we see from the skin tapes what we need to add? Because sort of the beauty and the curse now of IBD is we actually have so many meds, which is great, but now there are also so many combinations we could potentially use, and it's hard for us sometimes to pick those combinations. So I think the sky's the limit for what we can do from these skin tapes, but we did just need a lot of them to get that kind of follow-up over time, and to look and compare the skin tapes with the intestinal biopsies and see if they actually reflected one another. So that's still in process. And then, of course, we're hoping to use this in the prevention clinic to say the same thing. Can we use this as a window for the gut in a painless way so they don't have to undergo colonoscopy, but we can still get at that idea of what immune pathways maybe already off kilter or not off kilter. So that's kind of our skin. And then because of all of these links, we actually opened up an IBD dermatology clinic with Dr. Seises at Mount Sinai, where we can do skin tapes and some studies kind of based on the findings from the skin tapes. And it's really very nice for patients just because there's a lot of coexisting dermatologic and IBD conditions. And it's been great. Oh yes, the Rinvoq and acne. I could definitely talk on that. So that's another sort of passion thing that I have. We did do skin tapes for that. In addition to swabs, because there's a lot of microbiome, which is another sort of my areas of expertise. There's a lot of microbiome changes that are tied to acne. So we did skin tapes and skin swabs in people before they started Rinvoq. And then I did a survey of 100 of our patients who were started on Rinvoq. And we actually found that the rates of acne were much higher, which is what we were seeing in clinic, but they're much higher than what they were reported in studies. In the trial, it was like 4 to 7%. In another study, it was like 20%. And when we asked this 100 patients, it was actually almost 50%. It was just below 50% who had new or worsening acne on Rinvoq. And so with that, we actually developed with the dermatologist sort of a preventative strategy. So now we give patients who are starting Rinvoq just a regimen, a skincare regimen to follow with face washing morning and night, adapalene, which is a retinoid, and sunscreen in the morning. And I've actually seen a reduction in acne with that. And then beyond that, we also have found that dose reducing really can help with that. And then we're hoping to understand why it occurs because, people were shocked when they saw the side effect to Rinvoq because they actually thought it would reduce acne. It was thought that Rinvoq might be a treatment for acne because of the pathways that it impacts. And so dermatologists still do not know the pathogenesis. I've asked a couple of them, why does this occur? Like, what do you think is going on? And they have no idea. So that's what we're hoping that the skin tapes may actually tell us what's going on to better understand how to stop it. Um, Although our regimen actually turns out to be quite effective. So just a kind of a mild over-the-counter retinoid is more effective, I guess, than I would have expected. Um, but yeah, no understanding yet, but we're hoping to answer that. Uh, Anything else? Oh yeah, of course. All right, I can go to the next one. Okay. So the next is intestinal ultrasound. So again, Marla and I are both pediatric doctors, so we're always very cognizant of doing procedures in our patients and sort of the medical trauma that we're creating. So we really want to monitor and do everything with as minimal kind of invasive procedures as we possibly can. And as such, gosh, maybe like 10 years ago, Marla started thinking about intestinal ultrasound, um, and then made a really big push, really just before the pandemic, to start to bring it to the United States. And so she put a lot of effort and backing in making this happen with IBIS, which is the European group. And it led to, I think, an explosion, which you all are now seeing kind of the after effects of Marla really spearheading it all, and putting a number of her trainees now kind of in charge of disseminating that across the country, like Mike Dollinger, Amelia Keller at Chicago, Matt Smythe in Canada. They're all Marla trainees, just like me, who are disseminating intestinal ultrasound. And then, of course, me too. I learned back in 2020, deep pandemic, how to do the intestinal ultrasound in Europe, and brought it back to the IBD Center. But why we were so passionate, why Marla really thought this would be amazing is we see all the time that I think in clinic we had this common scope where we'd just be trying to see how extensive colitis was. And we kept being really frustrated, saying, like, I wish there was just another way. And in Crohn's disease, where you'd see the patient and what they were saying wasn't really matching up with what you thought was going on. And we didn't have a way of looking inside aside from a colonoscopy or an MRI, which Marla hates an MRE because of how it impacts the patient. Me too, to be honest. But we wanted some other strategy, and ultrasound really fits that. So is it good though? Like you might say, well, it's great that it's not invasive, but is it good? And it is very good. Europe had been doing quite a number of studies on it and showing that it was actually very good, very similar to our MRI and our endoscopy. And when the data was there, it was very clear that we should be doing it here in the United States as well. So for detecting Crohn's disease, it's 92% accurate. If you compare that to an MRI, it's 97% for an MRI. So very similar in accuracy. For endoscopy, for both ulcerative colitis and Crohn's, it is strongly correlated with our scores for both diseases. This is nearly as strong as you can get for some of our kind of clinical scores. So a very strong correlation. So telling us it's really very good. There's only like a few limitations for it that we still trying to troubleshoot. Like the rectum is a little bit harder to see. So people who have very limited disease at the end of their colon, it's still a little bit more difficult. For the pouch, Maya Kayal at Sinai is working on doing different strategies to better visualize the pouch. Perianal disease, again, requires some more sort of finesse with the ultrasound. So there's still some kind of gaps with the ultrasound, but even that we're working on trying to see if we can fill because it's just so good at other parts of IBD. And then beyond that, it changes in real time, which also makes it great. So You can really see measurable improvements 8 to 12 weeks after you start a therapy, and actually shorter than that. That's just a lot of the studies are at the end of induction for a therapy, so they're at the 8 to 12 week mark. But we've even shown in the hospital that you can see changes over the course of a day with some of our therapies in an admitted patient. So it's really good for that monitoring that Marla was talking about before, and can feedback that real time to the patient. So you can turn the screen to them, they can see it, and they can actually see the change. And even if symptomatically they're not feeling the change yet totally, that I think is really, it gives them hope, which is really nice to be able to do in that real time way. And then beyond that, um, Marla's really, it's not just for Sinai. She's doing this, she's been a champion for kind of democratizing this across the country and making sure that training happens for everyone and that every IBD patient can really experience and have this care, which is really nice. So what is it, by the way? We've been talking like a ton about it. I think many of you have probably had one or seen one or sort of know what it is, but maybe you haven't. So just to show you what it is, this is actually a paper from Amelia Keller, who's now at Chicago, showing how it's done. So we start here in the sigmoid colon. Um, so that's near the end of the colon. You can see it beautifully. This is a normal intestine in all of these pictures. And you can see the haustration. The colon looks scalloped. And that's normal. That it's a nice colon to see when it's scalloped like that. And you can follow it up along the side to look at the descending colon over here. Still looks that nice haustration, that scalloping that we see. Then we can go across for the transverse colon. Again, sort of that nice scalloped look, and then down for the ascending colon. And you can really track the colon all the way around really very nicely. And then you end in the terminal ileum, so the very end of the small intestine over here, labeled TI. And we can see that all really, really well. Higher up in the small bowel, you can see roughly too by doing sort of a lawnmower motion up and down. But all told, this takes maybe at most 10 minutes, usually closer to like 5 minutes to do. And then what does it look like? We just showed you the normal with that one going all the way around, which you can see here, the same normal. It's like an Oreo look to the wall is what we commonly will tell patients, which is that it should be a black, white, and black. The submucosa is this white one, and it's often where it will get thickened in inflammatory bowel disease, sort of swollen. And that's what we're looking for. We're looking, is it thickened and is there blood flow to it? Because that's an inflamed wall. There are other findings that we can look for too. Like sometimes it'll be like highlighted in white around it, and that's actually fat, inflammatory fat. There are lymph nodes that you can see when your immune system is really activated. And then you can lose the beautiful layering of the walls. You can see these nice crisp lines over here in the normal. You start to lose that when someone has a lot of inflammation, and that's called a loss of stratification. So you lose the lines. Over here, you can see an inflamed one. You haven't really lost the lines so much, but you do have a really big, thick wall. And I would imagine if you put your Doppler, which is that color flow, it's showing the blood vessels moving over it, you probably would see a lot of color in this. So you can see this is just a thickened segment. We're tracking it, but you can really track it very nicely in real time and show kind of where it stops and starts. So Marla and I, when we would ask that question of how much, like how long is the segment, is the patient just having a ton of symptoms from a tiny spot, or is it a long segment? We can answer that very, very well with this. And then you can also say, in some people, just scarring can make it a little thicker, but you can say, is this actually active right now? And that's what we look for, this blood flow to it, because that's actually activity right now. So you see this red and the blue in the colon wall right here, and that's activity. And then this is just what I was saying before, is that it's just really nice for patients to be able to see this. I think they often don't really, like seeing is believing a little bit, and you can't like see inside. You can feel the symptoms, but you don't really know by looking. And so the ultrasound gives us something to actually look at without doing a colonoscopy. And so patients really agreed with this. They thought they knew a lot more about their disease. And I will tell you from doing ultrasound over the last 6 months, I did a lot of ultrasounds as we're sort of transitioning. And some patients before I did the ultrasound did not know where their disease was located. They couldn't tell me. And after they definitely did. So it's a nice kind of education tool as well to give them just a little bit more agency and knowledge about their disease. And it also really helps them understand where their symptoms come from. Sometimes I'll have people go, "Oh, that's exactly where my pain is," when I show them the inflamed segment. And it really is like a light bulb moment, which is, I think it's nice. It's useful for the patients. And then it really helps them to make more informed decisions. Um, when like if someone we've had like people be sick for the ultrasound so they couldn't get an ultrasound that day, like when our tech or when the Nancy will tell you the story when like someone was absent because they were giving a talk, so the person that was supposed to do the ultrasound couldn't do it a day. The patients will say, oh, it's like I'm blind sort of in making this decision. So it really is just, it's become a cornerstone of our care. And I think you'd say that too, Marla, right, that it's a real cornerstone of your
Mhm.
care
Yeah.
at this point. Um, and so this is just like our team right now at Sinai, a bunch of ladies actually. I was realizing as I was making this slide. Maya Kayal, who has expertise in pouch, who's really trying to make it really more about the pouch and be able to see the with the ultrasound the pouch, which would be really great for us so that people don't have to undergo pouchoscopy. Brianna Evans, who's one of our trainees, who's really like a shining star for pediatrics and will be amazing. And then Zoe Gottlieb is actually going to take over our ultrasound program. And she also has expertise. She does the pregnancy clinic with Marla iPrep. And ultrasound, as you might imagine, is a really great tool for pregnancy. You don't want to scope a pregnant patient, and you can actually see a lot of the intestine while pregnant, even late. I had a woman who one of the doctors referred a week before she was due. And I could actually see lots of segments of her colon very well, even a week before she was due. So a really great tool in pregnancy. And then Amelia Keller, who I talked about before, who's now at University of Chicago, because again, the idea is not just to keep it at Sinai, but to collaborate and scale this more broadly. And then we make a bunch of collaborators where we can have these amazing trials on how to incorporate intestinal ultrasound and to get as far away from colonoscopy as we can, except like Marla was saying, in the cases where we need biopsy. Um, Effective for patients with ostomies. I and jejunal and duodenal Crohn's. Yeah, those are the sort of one of the jejunal duodenal. It's difficult. Duodenal, especially, just because the duodenum is really in your back, sort of. It's very difficult to see. Jejunal, if you have severe jejunal disease, we can see it. I actually have seen some jejunal disease on the ultrasound doing that up and down kind of lawnmower motion. But it isn't the best because it's harder to locate. You can sort of give a rough estimate of where you think a disease is. And MRE is a little bit better to exactly localize that small bowel disease. And it can be effective for patients with ostomies, not right at the site so much sometimes. So you can go around, and it depends a little bit what you're looking for, I suppose. But yes, there are some uses in ostomies. I feel like you've done it before in a couple of your ostomy patients, Marla, but with a very specific question in mind, usually. But yes, we do that. And then what we don't like about MREs, they're just uncomfortable. The exam, you have to drink a lot of liquid. And again, we're pediatric gastroenterologists. I can't say I have any patients running to do an MRE when they have to drink all the liquid. And usually they're saying it's one of the worst tests that we do on them. That's just the feedback that we've gotten. And it's just from the discomfort of the exam. They're also, they lack sometimes in like I do think that sometimes we can see things on the ultrasound that the MRE is a little bit more equivocal on. Um, what can it not detect? It can detect stricture. Uh, what can it not detect? It can detect most things, I guess. The rectum, again, is it's just a little bit harder, although there are some who are very experienced and can see the rectum well. And then there's some limitations by body habitus or even I've had people who have like bowel obstructions sent to me, which might isn't really the ideal patient because they have a lot of air in them. So air is not it's an enemy of the ultrasound, so it's a little bit difficult to see when someone is full of air. So there are limitations sometimes. And then body habitus, plus minus, sometimes when you have more fat, it's like a little harder to see through with the ultrasound. So that can sometimes be limiting, although less than we originally thought, actually, I gotta say. Um, you can detect rectovaginal fistulas. Again, it's just that location deep in the pelvis can sometimes be hard, but you can see fistula, and it depends on kind of how good your perianal and kind of rectal views are. But rectovaginal actually might not be so hard. You can see that area pretty well. Um, so yes, you can detect all of these things. And again, some of it's just skill. If you know, we've trained a lot of people at Mount Sinai over the last like 3 years, but some of the folks in Europe have been doing this for like 20, 25 years. And so they're going to have more skill in doing some of these like finer and more difficult complications than someone we trained last year. So the bread and butter is going to be for us for the monitoring, which is your day-to-day use, which is to say, is this therapy effective? Are you in remission? And if someone is newly trained, they might look first for the ultrasound and still want you to get a follow-up imaging study if they're really worried about one of these complications that maybe they don't have the skill, or maybe sometimes it's lifelong training a little bit to get some of this more nuanced skill over time. And it's still early. Like I'm one of the first trained in the US, and I was trained 5 years ago. um, I don't know what else do you think, Marla?
No, I think that's it. I think that the just to give you some background is that in Europe, all GI fellows are trained on ultrasound as part of their training. That is not the case in the United States. And fun fact, my first ever paper in 1998, because in Canada, similar to Europe, where we don't have the money to spend on CT enterographies and MRI. It wasn't even a thing, MRE at that point, not even, I don't think CT. That's how long ago it was. I did train before Remicade was in our hands, so it does give you a perspective on how long ago that was. But my first paper in 1998 was on the use of Doppler ultrasound to detect disease activity. That was 1998. And so, as Lizzie said, it was my mission to
Yeah.
actually bring it. And I've unleashed a beast, which I'm happy to say, in the United States, which is to finally bring the right amount, the use of ultrasound bedside into patients because it was ridiculous. So, the fact that everywhere else in the world was years ahead, yet we had the best, research and clinics in the world. So it just didn't make sense that we were missing that asset for patient-centered care. So ultrasound will is continuing to evolve. We've actually are getting it to be used in clinical trials now, which is another major win for us, is that they're going to be looking at using ultrasound to look at response to treatment in clinical trials, which is awesome. And so that is another win for drugs, because one of the meaning efficacy of drugs, not for drugs themselves, but that the International Organization of Inflammatory Bowel Disease is what started this whole concept of treat to target, and moved from symptoms to endoscopy, or colonoscopy, as I was noting before. And actually, what's really interesting is that the next guideline is going to be that our drugs should actually achieve transmural remission, which means ultrasound or MRI. So it's not going to be good enough to get a scope that looks good in someone with Crohn's disease in particular, because normal scope does not always mean no surgery, right? So the concept is that the main reason why we may not be moving the needle as much as we would have liked to have with all these incredible therapies we have is because we're measuring the wrong thing. We're only measuring one layer of the bowel wall, and there are 4 layers to the bowel wall. And the most important layer is below what we see at endoscopy for Crohn's disease, and that is the muscle and the submucosa, which is where collagen or fiber is deposited, and the muscle layer. And that's what narrowings are from. It's muscle hypertrophy, so the bowel wall, the third layer. Lizzie showed you black, white, but those are the four layers, particularly of the bowel wall. And where scar tissue gets deposited isn't on the wall that any of us see at endoscopy. It's underneath it, which is why our guidance is going to be that our treatments need to not just achieve a beautiful colonoscopy picture, but also a beautiful ultrasound image. So that's sort of the next frontier in what we are expecting our drugs to be able to do to truly change the trajectory of people with IBD. So you heard tonight a very extensive sort of approach to, as Lizzie started, a patient journey, right? And that's sort of the premise behind all the work that we do. And if it doesn't help somebody tomorrow, we're not publishing it. That's our motto. So we're not doing Me Too research at all. We're actually leading, and others could do Me Too and validate what we found at Mount Sinai. But the point being is, if it's not going to change a life tomorrow and improve one person's life by one provider reading that paper or understanding how to use these tools, that's not good enough, right? So our whole mission really is sort of what Lizzie presented, other than these fabulous females that are on the slide, by the way, for everybody to know. Clearly, we've got a strong future female likable badasses that are coming up and leading the field, just to show you that there's a lot of future generation that are focused on really big ideas. And support through organizations and through foundations and philanthropic partners is what gets us to change the future of people's lives with IBD and prevent it. And that's sort of what we hope. We shared with you a lot of the excitement of what's, as Lizzie said, rethinking what's actually possible. Yeah, so we'll leave it there. Lizzie was going to say that obviously, thank you, Jen. But one of the other future areas of interest, which is the hottest topic on the planet, obviously, is GLP-1s,
GLP-1. Yeah.
Zepbound, Manjaro, Ozempic. But to be fair, beyond everything that's happening in the world of obviously obesity and weight management, type 2 diabetes, we're actually looking at how GLP-1s may actually be a treatment for IBD. So stay tuned for a lot of really cool work based on the mechanism of inflammation, and fat is very inflammatory. And so individuals who have high visceral fat, which is sort of way underneath, not what's under your skin, but deeper, as Lizzie's showing you there, which is more white fat, not brown fat. But white fat is a driver of all of the same targets that our treatments go after. It's basically a volcanic eruption of all of the inflammatory proteins, and our drugs work better when we lower the visceral adiposity. So there are trials being done where we're combining GLP-1 with our IBD drugs. So we have a whole WeightWise clinic developed solely focused on obesity management in people with inflammatory bowel disease and using GLP-1s in combination with our IBD treatments. And the outcomes are pretty staggering. People do better in their disease, their treatments work better, less hospitalizations, and a lot of other news. So probably the next 5 years will be, Lizzie pretty well outlined exactly what is going to be happening in the next 5 years in inflammatory bowel disease. So, and we're proud to say that we're driving the field. So that continues to be our force of nature at the work we're doing.